So I spent a fair amount of time trying to figure out how to be efficient during COVID, and I really didn't want to touch patients or be in the room longer than I really had to. So this is how I got my physical exam down to a couple minutes. Okay, same disclosures. So the first, using the same questions, I try to get through any office exam for the shoulder in about 3 minutes. So I'm going to do a visual inspection. I'm going to push anywhere that it hurts because it really helps rule out exam. I'm going to go through motion because that's going to be my biggest differentiating factor. And then I'm going to test the rotator cuff and biceps. If patients have dislocations, that's a different exam that we'll cover more tomorrow in the hands-on sessions. So looking at the shoulder, just remember your anatomy. When you look at the back of the shoulder, you can see the infraspinatus fossa, you can see the supraspinatus fossa, and in the front of the shoulder, you'll be able to see your AC joint, any AC joint arthritis, and any abnormalities. When you see a hole or essentially atrophy of the infraspinatus, the chances that they have a rotator cuff tear is really, really high. So if you see noticeable atrophy, like this is showing here compared to the other side, you want to think that this person has a chronic rotator cuff problem. So this is why you always want to be able to have the patient take the shirt off and show what their shoulder looks like. Next thing is I want to press where it hurts. So obviously, if they have a clavicle fracture, they landed hard on the clavicle, they're going to be sore where the fracture is. If they're tender at the AC joint, that tends to be AC joint arthritis. Most of the time, an MRI evaluation is going to show horrible degenerative changes in the AC joint. That is not shoulder arthritis. That's actually a normal finding. So when they have that, I will usually push on a patient's AC joint and say, look, it's not your AC joint. That's a normal finding. If they tend to have pain up here in the trapezius, that tends to be a muscle strain. We'll talk about how to find the biceps. And if they're sore in the back of the shoulder, that tends to be arthritis. So the next thing I do is do range of motion. I ask a patient, what can you do? Can you get your arms all the way above your shoulder? Can you get them all the way down? If they've got full range of motion, they can get their arm 100% up. They don't have arthritis. They don't have a clinically significant rotator cuff tear, and they don't have frozen shoulder. Yeah, do have to be a little bit careful, especially with older patients. They'll be like, yeah, I can get my arm all the way up, but they're only up at about 90 degrees. If they can't get their arm all the way up, they have difficulty with active range of motion, then you want to check their passive range of motion. So if you can passively get them all the way up and they have difficulty holding it up, it's a muscle problem. So think rotator cuff tear. If they have a problem with passive and active range of motion, it's either shoulder arthritis or frozen shoulder. When we do rotator cuff testing, we talk about impingement signs and strength testing. The best way to examine rotator cuff disease is that it's hard. There's, these Cochrane summary says that there's not a perfect test for rotator cuff problems, but JAMA came up with a really nice study in 2013, and I like a lot of what they said through this. And the best test that I have is painful arc. So the patient says I can get their arm all the way up, and as they come down, they have pain through this area. And if they say yes, they have pain through this area after having a full range of motion, so they don't have frozen shoulder, but they have pain through here, they have some sort of rotator cuff pathology. It doesn't tell you if it's a full or partial thickness tear, it just tells you that their rotator cuff is irritated. The drop arm test is really good for a tear of the rotator cuff. You bring their arm up like this, they cannot hold it up. That suggests that they have an actual tear in the rotator cuff. Impingement signs, I think, are a little bit harder to do. Hawkins test, I remember by having your arm like a hawk and then painfully internally rotating, but that's going to be positive no matter what they have. So you want to make sure they don't have frozen shoulder, they don't have arthritis. If they have a Hawkins, positive NIRS, positive Hawkins, that tends to be positive for impingement if they have nothing else. When we look at sensitivity and specificity, they're decent tests. They're not amazing like all tests in the shoulder. When we test supraspinatus, the most common one is Job's test, which is both a test for strength and function. So you have the patients up like this, and then you push down, and you're looking for asymmetries or a patient describing it as different. When you look at infraspinatus, you want to keep the arms at the side and have them externally rotate. And the main thing is it's not really a strength test for their deltoids or their big muscles in the back. You really just want them rotating. And we'll go over how you do that effectively. And subscapularis, I really like the test on the right, the bear hug test, where they bring the arm over like this and you raise up. A lot of patients can't physically get to their back, like the lift-off test. I personally think it's a little bit more reliable for patients that know what you're looking for, but this one's easier to do in clinic, so more and more I do the bear hug test. And then biceps test, there's two really good tests. One is O'Brien's test, which I think is a good test for younger patients when you think they have a superior labral tear. And then there's my favorite, which is biceps tendonitis. Also, this guy has awesome hair, so I always keep this slide in, where you want to find whether or not there's tenderness at the bicipital groove. I've stopped doing Yergenson's and Speed's tests because I find they're really non-specific. Really, I want to find the biceps, push on it, and see if that reproduces their pain. And people with biceps tendonitis are almost universally, you find the biceps tendon, you press on it, and then they say they have pain, and you've confirmed the diagnosis. So I'm going to stop there and transition to showing how to do this.
Okay, hi. All right, so are we good? All right, so this is, I will be honest, super awkward to be doing this because I have somebody with a camera holding a gimbal. So I'm going to pretend I'm Tom Cruise and be short and go over how I do a shoulder exam. So this is Cam, she's one of our athletic trainers. We are going to pretend you are in your 40s to 50s and not really, no, 40s to 50s, you're fine. Okay. All right, you'll get old soon, don't worry. And we're gonna go over how I like to do a shoulder exam relatively efficiently. The first thing we're gonna do though is we're gonna point out a little bit of anatomy. So let me have you stand up. And most of your shoulder actually comes from the back of your body. So I'm gonna pull this out of the way a little bit. Your shoulder blade is back here. So when we talked about infraspinatus fossa, that's this part here. So your whole infraspinatus comes over and attaches here. Your supraspinatus fossa sits underneath your trap. So this is your supraspinatus fossa here. So people with a rotator cuff tear or have a chronic rotator cuff tear with atrophy tend to have a little defect here compared to the other side. And then this is your trap here. So things that you can kind of figure out when you look at the back of a shoulder is whether or not they have any atrophy. Patients, for what it's worth, we'll cover this later, but people with cervical spine pain tend to have pain that come down in here, and then they will have pain kind of up in this area. So people with C3, C4 problems will say it's my shoulder, but it's actually right here that my shoulder hurts. So those patients you want to kind of rule out. When you look at the front parts of the shoulder, the things that patients will have problems with is their collarbone, which is this part here. The only real problem you can have with your collarbone is you can break it, and their AC joint. And their AC joint you find by finding the tip of the acromion here, and then you can press right on the AC joint, which is that first bump you feel as you walk down, okay? So if a patient comes in and they say that they have shoulder pain, like I said, the first thing we're gonna do is we're gonna look at them, and then I'm going to ask them where they hurt. And I will say, take one finger and press where that hurts. So if it's their AC joint, they'll tend to press right here. If it's arthritis, they'll tend to say it's kind of in the back here. If they say it's kind of all back in here and they can't, it's that one they can't put their finger on, I'm thinking that that's their cervical spine. If it's like, well, my pain is down here, it can't be my rotator cuff because I know my rotator cuff is up here. I'm like, well, actually rotator cuff tends to refer down here. And biceps, they will almost universally find a spot right here. So that helps me really differentiate how, what I'm going to look for. So look, palpate by asking a patient where it bothers them. So if a patient says, well, it hurts in the front of the shoulder, I'll say, okay, well, I'm just going to push along your biceps. I'm going to push along your AC joint. Next thing I ask them to do is, how is your range of motion? So can you get your arms all the way up? And can you come down medium speed? So go all the way up again. So by definition, Cam does not have frozen shoulder yet. Yes, will soon, don't worry. And then come down slowly. And this painful arc, if somebody has a rotator cuff problem, is going to happen from 120 degrees down to here. Okay, and come all the way down. So I'll ask a patient to do that. If they can't get their arms all the way up, I'm thinking frozen shoulder arthritis. If they can come all the way up, I'll have them come down medium speed. I don't test internal and external rotation unless they seem to have some sort of defect with abduction and forward flexion. The other thing I want to look at is how they move their shoulder up. So if somebody who has a rotator cuff tear for a long time can sometimes swing their shoulder up, and still get their arm up because they're using these muscles back here, and they will use their trap a lot. So a lot of times patients with a rotator cuff problem will hold their arm up by firing their trap, but when you push on them, they're actually pretty weak. That was a really good thing, okay? So once I've tested their range of motion, if they have good range of motion, the next thing I'm gonna do is test their strength. So for testing their strength, I'm thinking of testing their supraspinatus, followed by their infraspinatus, followed by their subscapularis. So for supraspinatus, walk all the way in front of you, I'm gonna have their arms up. It doesn't really matter, thumbs down or thumbs up, but if you're not sure, I usually just keep them neutral to a little bit with their thumbs in. Hold your arms up, don't let me push down. It's not pushing that hard, it's not a strength challenge. It's more just pushing to see if there's a difference and to see if there's a difference in the amount that they recruit. So patients with a rotator cuff tear, if you push on them, they'll often keep their arm up, but they'll fire their muscles differently, or they'll say it feels different. Next thing I test is external rotation. So this is looking for a tear that maybe is a little bit bigger or extends towards the back. So they're going to be weak in that ability to fire their infraspinatus. So what I do is I have patients say, bring your arms out to about here. Don't let me push in. Just keep your arms just like that. So if they can hold it there, they don't have a significant infraspinatus tear. Patients who are weak, when you push on them, come in pretty easily. In fact, if they have an external rotation lag, they can't even bring their arm out. It'll just kind of snap back. So you can bring them out and then it'll snap back. That suggests it's a larger chronic tear. The next test I do is looking at your subscapularis. So you can sort of think of it as, well, if you can test external rotation, why can't you just test internal rotation like this? It's because your pec muscle is too strong, some more than others. So just pushing in, so push in, is a really nice test for just kind of, to a certain extent, is everything just sore and non-specific? Because the patient is like, oh, that's the same pain as I had this way. It means that it isn't really coming from the shoulder. They're just kind of sore. So the best way to test your subscap, I think, is to move your hair, put your hand here and say, don't let me lift off. Be as strong as you can. And people who have a subscap tear will actually lift off pretty easily. So usually what happens is their fingers stay on, but their wrist comes up. People who don't have a subscap tear, like, now be as strong as you can. You feel like you can lift them all the way up to the ceiling. A couple of random things. I will always push from down here rather than pull up. I've slipped a couple times and hit people in the face. Let me demonstrate that again. You kind of just hit them, especially if they've lotioned themselves or you've just washed your hands. It can be slippery. So, and then I have them just pull down and then lift off. And I try to keep their elbow up. The higher up their elbow is, the more it's testing the upper half of subscap, which is where most tears are. Okay. The next test, the hardest test, is O'Brien's test. And the only thing we're really doing with O'Brien's test is testing people under the age of 35 for a superior labral tear. Other than that, it is not a good test. So what we do with that is we take the arm in front. So if you think about Job's test was like this, this is Job's test, but all the way over on the other side of the shoulder. So you can bring the arm all the way over. I want the thumb in front of the other shoulder. And then I'm going to say, keep your arm up. Don't let me push down. Okay, so be as strong as you can. People with a positive O'Brien's, when you push down, they'll say, that's my pain. And it's usually actually in the back of the shoulder. Okay, so if you push down, they say, ow, that's my pain. Turn their wrist over and say, is it better, worse, or the same? When you push down, they'll usually say, almost always they'll say it's better. If you say, does this hurt? It's an irritating test. So it will always irritate patient. Yeah, that hurts. And then if you say, is it better like this? They almost always say yes, because they're trying to just feel different and you're coaching them. So I try to say, does this reproduce your pain? Because that's a little different than does it hurt? And better, worse, or the same doesn't coach them. So a patient that is like this and says, it's not quite my pain, but yes, it hurts. And yeah, that's actually worse like this, is a non-specific exam. So a positive O'Brien's is thumb down, reproduces pain, thumb up in the same position, feels better. That can suggest you have a superior labral tear. So last thing is biceps. So your biceps is kind of a weird, poorly designed structure. There's two heads. So one comes off the coracoid and goes down the arm. The other one is attached essentially between two parts of your rotator cuff and moves with your shoulder. So if you feel on yourself, you can feel your lesser tuberosity, feel your greater tuberosity, and then in between is where your biceps tendon is. So people with biceps tendonitis think, gosh, sometimes I can feel where it is, sometimes I can't. And that's because your biceps actually moves a little bit. It is between this group. So what I do is I keep the arm out about 30 degrees because then it's going to be pointed straight at me. I try to find those two little bumps, and then I push about 3 centimeters down from the AC joint. And patients with biceps tendonitis will say, this hurts, that's my pain. You can confirm that now by moving the biceps out of the way. So now you've internally rotated, the biceps is now hiding farther over here. You press on the skin on the exact same spot. They say, I feel better. You press on it again and externally rotated, that's worse, better. It is a spot that's a little bit irritating. So I usually compare to the other side, and most patients, it's rare to have biceps tendonitis on both sides. So if you press on that side, it tends to reproduce their pain. They say it feels better. So in summary, this is how I do the exam. So nice to meet you. I'm just going to have you do a couple things. I look at their shoulder. If they don't have any place where it hurts, I'm really not going to press on them except for really quickly. I'll press on their AC joint just to make sure. I'll test their biceps a little bit. You raise your arms all the way up, and then can you come down kind of medium speed? Any pain when you do that? No? Okay, good. All right, can you put your arms down like this? Can you rotate out, come back? Good. I'm going to borrow your arms. Bring your arms all the way up. Don't let me push down. Be as strong as you can. Good. Feels about the same on both sides? Okay, good. Put your arms down like this. Come out about halfway. Keep your arms there. Don't let me push in. Good. Feels about the same? Okay, I'm going to borrow this arm. Put it here. Don't let me lift up. Be as strong as you can. Good. Okay. Good. I'm going to borrow this arm. We'll do it. O'Brien's test on the other side. Keep your arm up. Don't let me push down. Okay. Does that hurt? No. Does it reproduce the pain that brought you in today? Good. Okay. Yeah. Clearly, you weren't coached before this. Better, worse, or the same? Okay, good. We're going to operate on you now. Just kidding. Okay. And then again, to test biceps, I'm going to have the arm out like this, push in here. If that hurts, I'm going to rotate out of the way. Oh, they should feel better. So that should be a relatively efficient exam. I encourage you to practice this. Everybody has their own test that they do. The last thing I do at the very end is Neers and Hawkins. And the reason why I only do that if other things are positive is because if I'm still not sure, I don't think they're very good tests. But the way I do Neers test is I have their arm down like this. I kind of bring them up like this most of the way and just push the last little bit. And then Hawkins, I don't think is a very good exam. But you bring the arm in like this and you just internally rotate. The last thing I wanted to cover before I forget is the best range of motion test for frozen shoulder. So a lot of times people with frozen shoulder, if you turn sideways, will say, I've got really good range of motion. See, I can get my arm up to here, and then they bend their elbow because you can still reach everything like this, but they think they've got full range of motion, and you can kind of push them and they lean backwards and you can get good range of motion. What all patients with frozen shoulder have lost is internal rotation with their arm up at 90 degrees. So if Cam relaxes her arm, she's got good range of motion. She can get internal rotation to about 80 degrees and can come all the way up like this. Somebody with frozen shoulder cannot rotate in. And in fact, if you have frozen shoulder, almost always what happens is your shoulder blade rotates, but you're not moving your glenohumeral joint at all. And it feels like you're being locked in. And then they start losing external rotation. So this is by far the best exam for frozen shoulder. And when patients sound like frozen shoulder and they come in, all their questions seem like frozen shoulder, I simply bring their arm up like this. And if they can't rotate in, by definition, they have frozen shoulder. Okay. All right. So I'm going to stop there. This is the first time we've done exam in a blank room in a warehouse. So hopefully you all have questions and I can answer some questions. Okay.
Thanks, Brian. That was great. We had a question about how you treat rotator cuff tears in the elderly. Want to come here?
Okay. All right. So
Okay, rotator cuff tears over the age of 80. For the most part, when I see patients with a rotator cuff tear over the age of 80, I will say that you really have three options. We can do physical therapy and possibly an injection. We can do surgery, and they immediately start shaking their heads and say, no, there's no way I want to do that. Or we can do a shoulder replacement should you get worse over time. Most patients over the age of 80 actually do really well with non-operative management. So over 80, I will kind of push non-operative management. 70 to 80, as you all probably are aware, is a very wide variety of patients. There are some patients that are super active, 72-year-olds. If they have a rotator cuff tear, I will consider pushing them to surgery because I want to keep them active for another 12, 15 years. If they are lower demand, have a lot of metabolic problems, I think there's a high rate of re-tear, then I will push non-operative management. In fact, in the YouTube video that was in my talk, Peter Chalmers has a risk of re-tear calculator that you can go in and put in a couple different factors for the patient and give them an estimate of how likely the surgery is to work. I assume I will just read additional questions. Okay.
Another one, can you go over subacromial bursitis exam findings versus impingement and how they interact? Okay, subacromial bursitis and impingement, as far as I can tell, are the same. There's a lot of different terms because we don't entirely understand the pathology. So when I divide out in my head patients with whether they've been diagnosed with bursitis or impingement or small bursal-sided tears, the algorithm, as far as I'm concerned, is exactly the same. They are going to be treated primarily with a period of time of activity modification. So I tell them to take a break from what they're doing, decrease inflammation. So the decrease in inflammation is going to be to improve their symptoms and then to improve their mechanics. So that's get their rotator cuff stronger compared to their deltoid. And especially as we get older, our big muscles tend to take over for our smaller muscles. So our deltoid gets stronger as our rotator cuff gets relatively weaker. So especially over the ages of 40, 45, for your patients that are still really active, physical therapy tends to work really, really well. Great. We could do one more. Someone had a question which I addressed, but would love to hear your thoughts. They are sometimes asked to differentiate acute versus chronic rotator cuff tears on imaging. And what's your perspective on that?
Sure. So can we differentiate acute versus chronic rotator cuff tears on imaging? Usually we can. So the things that we look for largely is what the quality of the muscle is. So with an acute rotator cuff tear, even if it's a big tear, the muscle quality looks fine. There are also secondary things you can see. The tendon tends to be a little bit more wavy. There's more edema around the shoulder. For people with chronic rotator cuff tear, so the patient that says, well, they told me I've got a big rotator cuff tear, but I never had symptoms before, the muscle is degenerated. So we'll see a smaller muscle, we'll see more fatty infiltration within the muscle, and that tends to be the best indicator of acute versus chronic. Okay, thank you.